All right, welcome. April 15th Q&A session. Over to you, Simon.
No.
Hey, all right. So I have a 9.5-year-old who lost the lower right D early, and the 4 premolar is erupting before the C is lost. We are tight for space for the 3, and the C is mobile. We are expanding the lower and advancing the lower cat wires to gain more canine space. The E is a good size. Would you consider slightly enamelplasty on the mesial of the E to create more eruption space for the 4? And encourage it to erupt distally as it cannot erupt mesially because the C is in place. If so, I should have considered that prior to fabricating the new lower. And now that the lower E is classed, could I still do enamelplasty? Again, my reasoning is because the movement of 4 doesn't have enough room to erupt between the current E and the C, and even though we're expanding, this will take some time to create space. Normally I don't change the size of the E. So normally no, I don't do enamelplasty. So expansion and tipping of the lower incisors is what we normally do. So it's not a normal procedure. In fact, I don't think I've ever done it before. So it's very rare that I can't get room with the combination of expansion of the transverse dimension and tipping of the incisors. So let's keep going with what you're doing. Next question. Let's say we complete phase 1 by 9.5 on a patient, and now we have current upper and lower stage 1 appliances being worn passively. It will be around 6 months to the lower C's get loose, and then the changeover starts between the permanent 3, 4, 5 premolars and canine. How do you manage this passive retention period? I know we focus on go effects, but it's best to transition to nighttime retention until the E's exfoliate. Or is our goal to stop retainer wear altogether as soon as possible once posture is corrected, even though the D's and E's are still changing over? Will we be inhibiting further jaw and alveolar bone development by continuing to wear retainers at night? So retention is variable according to the patient, but as a general rule of thumb, it takes a long time for the children to break their habits. It's almost never the case at the end of treatment at 9.5 years of age that the tongue posture can be corrected decisively. So if you finish with the appliances at this period, you will get relapse. It will collapse. And then your gains will be lost. So when we finish the arch development and tidy up of the incisors at around this period, we will be expecting to continue wearing nighttime retention appliances until the E's exfoliate. That's usually the retention period. So at this point, when you've just finished the arch development, you're focusing on GoFX with a particular attention to the swallow to create a negative suction vacuum seal of tongue to palate at the end of each swallow. When we actually have achieved that goal, theoretically, the child will be self-sustaining of the changes that you've made, with the tongue now being the retainer. Theoretically, if you check their swallow, and every time you have verified that they're swallowing with an adult physiologic swallow and they get the vacuum seal and their posture is perfect, then at that point you can let everything go. My experience is at 9.5, at 10, at 11, every time I check, it's very rare that I have a child that has perfect posture. 7, 8 years of bad form can't be corrected overnight. It just doesn't happen. So we have a safety net of wearing the retainers at night, continuing ongoing practice of GoFX and GoPEX if necessary, if the habits of eating with the mouth open, talking with this food in the mouth, not punctuating sentences in speech correctly continues. Then we revert back to the original exercises, reading out loud, chewing at the dinner table, and we continue to practice our swallow. Use froggy mouth if that's part of that process, until we force a favorable long-term habitual change. Even if we have forced a long-term habitual change, there's no downside in retaining the arch form until it's time for leeway space to close, which is when the ears change over. All right. Next question is, in the case of an 8.5-year-old, where we have severe lower anterior crowding and extraction of lower Cs to allow lower incisors to come forward, and resolve lower anterior crowding using brackets 012 wire. Once the lower incisors are straight, and you want me to hold it for 6 weeks, but I continue to hold in 012 or change to 016 or other wire. So generally 012 isn't enough to level and align. It will unravel a lot of the heavy crowding, but it's not sufficiently large in its dimension to get a nice level and alignment of the teeth. So after the 012 is expressed, you definitely are going to be changing up to at least 1825 nighttime. And you can hold at that point in time. When would you go from 012 to 016? If it's very, very crowded and you can't get a rectangular Y in after the 012, you'll do an intermediate step of 016 for a further tidy up. And then when it's possible to get the 1825 9 tie in, that's the Y that's probably going to do the most to level and align. We're not doing mechanics in this orthodontic phase, so you don't have to go to a steel wire. But you'll need to be at least a rectangular wire of 17 or 1825 in the nickel titanium before you've achieved your goal of level and alignment. So you'll need to go from 012 to 1825. If you can't do that larger jump, then you'll go 012 or 016 and then 1825 after that. And then the passive hold for consolidation of the bone will be with the 1825. Okay, so next question is regarding the GoPex chewing exercise. We want the kids to chew hard and fast at the table to help talk the roots. But if kids are already struggling to eat with the plate due to food getting stuck, would it be helpful for them to use the silicone chews to chew for 3 minutes prior to eating? Then when they're eating, they can focus on teeth together swallow with the plates in. I think I understand the silicone chews are mostly for building up muscle tone. But could they be used in kids with good muscle tone but struggling to chew with appliances in place? So struggling to eat with the plates is a different process. It's a different issue compared to doing GoPex chewing, and a different issue compared to using the silicone chewies. Each of them ask different issues. They're all kind of intermingled with each other, but they're separate topics. And so interchanging one with the other is not really appropriate because you're dealing with different issues. When you start to think along the lines of this question, you're trying to make their life easier, all right, by substituting something easier instead of making them competent at each individual task. All right, my goal is to make them competent with each individual task. It effectively makes their life harder so that they can overcome hardship so that they can gain the favorable outcomes. When you're trying to figure out how to juggle different things that are easier to compensate for the fact that they can't overcome the hurdles, you're trying to make their life easier, but the downside is they don't get the favorable changes because you're compromising the protocols. So let's go through each of the separate protocols and why we do what we do. So the GoPex chewing exercise is to train them how to eat like grown-ups. All right, the GoPex chewing exercise is just a formalized form of good table manners. We eat with our lips sealed, we chew like we mean it, we break the food down until we can swallow the mush in the correct physiologic swallow, which is lips together, teeth together. Right? And eventually tongue on the roof of the mouth, squeezing progressively from the front to the back. Right? So that's the goal. We are doing that by training them to do all the things that we need to do in a physiologic swallow. So why is a physiologic swallow so important? Well, eventually it creates the vacuum seal that sustains the airway at nighttime, and the vacuum seal that creates really optimum posture that helps the jaws grow optimally and allows the teeth to line up nice and straight. We also have the concept that we are protecting the airway while we're eating, and we're making life easier for the digestive tract by masticating our foods thoroughly. When we are eating and talking and breathing, we run the risk of the food ending up in the lungs and choking to death. We run the risk that we're not developing sufficient breakdown of the food and mixing saliva into the enzymatic breakdown of the initial process and triggering the vagus nerve when we lift the palatoglossus, we activate the palatoglossus muscle in a physiologic swallow, so that digestion is better. That's the whole concept of table manners, is to protect the airway and get the gut working optimally to process the food into our system. When we focus on that one task, we are more likely to get the outcome that we want. When we're juggling eating and talking and breathing simultaneously, in a younger person who hasn't finessed those individual skill sets, we run the risk of choking to death and not digesting our food properly. So that's the whole point of GoPex, right? To help people understand that we master one task at a time before we add a second task into the process. What's the benefit? Well, protect the airway, good digestion. But you get another benefit. You get a good swallow, which results in good posture, which means that there's good growth and teeth line up nicely because you've got nice lip seal, you've got nice tongue to palate, you've got minimum freeway space, and teeth all erupt very tipped, either lingually or buccally. And then when you chew well, you torque the roots into a nice alignment so that everything socks in well and has that upright path of vertical distribution of forces when you're chewing. That's the whole point of good posture and good function. Get good growth and good alignment, good physiology, good biology. All right, but if you're not understanding the purpose of GoPex and you're not understanding why we want them to do those exercises well, then you get confused as to, oh, can they not have to eat with their plates in? Can they use the chewies instead? So why do we want them to eat with their plates in? How do we overcome the fact that food gets stuck? You've got to understand, mush doesn't get stuck in the plates. Solid bits of food get stuck in the plate. Why would solid bits of food get stuck in the plate? Because they're not chewing well before they try to swallow. They're not breaking the food down sufficiently that it's at a consistency level that it doesn't interbind with the plate. Of course, they'll struggle with a plate in place, but as you expand, more and more space opens up, and that's overcome. So is there going to be a period of hardship? Absolutely. Will that hardship pass if you persist? Yes. Will that hardship pass if you cater to their comfort and their distress without understanding that if they don't push through the hurdle, they will be stumped at the first point of resistance? Does food get trapped in the initial period? Absolutely. Will this lessen as you expand? Absolutely. Will this lessen as you do GoPex chewing properly? Absolutely. What's the chewies for? Chewies is going to the gym to build masseter and temporalis muscle. That's all it is. When do we use it? We use it for kids who have very low muscle tone. Do we need to use it for kids with good muscle tone? No, you don't. Okay. Next question. What exactly is the purpose of chewing with appliances in place other than not losing them, taking them in and out less, and helping with root talk? And are these reasons more important than chewing hard and fast at the dinner table? So eating with the plates in means that you're not going to run the risk of losing the plates because they're taking it out, multiple times a day. So that's the primary reason. Secondary reason is when you move teeth, they get sore. When they're sore, it's harder to chew. When you use expansion, but you have plates in, the plates act to help brace and support those developing arches, and they can chew harder with the plates in than without the plates. In addition, expansion is at a different rate in both arches. The expansion rate on the upper is much, much higher, faster, bigger than the lower arch. It's 2 to 3 times faster. When you expand the upper 2 to 3 times faster, at some point in the development, you're going to end up with a scissors bite. You can't chew in a scissors bite. So we design the plates with a ramp that allows for the fact that the upper will be expanded at a faster rate than the lower, but the child can continue to function normally in their eating because they have the bite ramp to chew on. So if you take the plates out when you're doing the expansion, not only will it be sore for them to eat because the teeth are moving and the bone is redeveloping constantly, and in addition, they won't be able to chew properly because the bite relationship will be so altered that they'll have nothing to work against, upper and lower, when they chew. Okay, next question. After you explain the teeth, after you explain that teeth to be half to 1 mil at rest posture, I found that I have to place my tongue just behind my incisors. My end spot can be between the gingiva incisor to 1 centimeter behind. How do we know exactly end spot? Isn't it different on the structures or fixed? So the end spot is the point where your tongue touches the palate when you pronunciate the letter N in a clear, concise, defined manner. Generally, that coincides with the tip of the tongue on the incisor papilla. When you don't put the tip of your tongue in the correct position, the sound N doesn't sound right. So the end spot is defined by having a clear, audible, correctly pronounced N. If your tongue doesn't touch the right spot, then your pronunciation of the letter N often sounds wrong. That's all it is. I can promise you, if you put the tip of your tongue a centimeter behind the incisive papilla, your N does not sound correct. And if you put it in front of the incisive papilla, your N doesn't sound right either. It'll sound like a lisp. and one will be muffled and one will be a lisp. So all the end spot is where your tongue touches as you pronounce the letter N correctly. Now, will that change depending on the malocclusion? Of course. This is assuming that you are in a moderate degree of malocclusion or correctly skeletally based in balance. All right, so if you got a massive class 3 or a massive class 2 or massive open bite, you're never going to sound right saying anything. So it's not going to create the right soundings. So a lot of this must be focused on the finishing process, right? The GoFX. End spot exercise is at the finishing stage, and the finishing stage is only appropriate for kids who got kind of reasonable bite relationship and occlusions. All right, this is why all these myofunctional exercises before addressing structure issues is such a waste of time and energy. You physically can't do the optimum performance if structurally you're out by a long way. If you're off a little bit, sure, the exercises, any exercises will have benefit. But if you're out a long way, exercises is literally wasting everyone's time, energy, and money. Okay, to train, strengthen the posterior part of the tongue, have you used the MyoSpot, REM, plenish myonozzle, and up blocker vacuum? Up blocker vacuum can measure the tongue pressure. How much tongue pressure is enough to get the tongue suction throughout the night? Please recommend methods accessible for most patients. MyoSpot encourages a better tongue positioning because you're giving a physical marker for the child to feel. So sure, if you put the spots along the palate at the front, the middle, and towards the back, then you're more likely for them to make a change that is favorable because they can feel the tip of the tongue on the first spot in the incisor papilla, they can feel the middle of the tongue and the middle of the palate, and then you might put one just in front of the vibrating line so that they can feel the back. So sure. Do I use it? I haven't. I've got them sitting on my desk. So can you use them? Absolutely. There's no downside to using those, so go for it. The myonozzle, again, it's a similar process. Up locker vacuum seal. It's just a different approach to the GoFX exercises. At the moment, what I'm using as far as gadgets are concerned for that correct swallow is froggy mouth. Okay. All the other MyoSpot is widely available and it's inexpensive, so I'm happy for you to give that a go. The uplocker vacuum is not readily available, but by all means, if you can access it, use it. Same with the myonozzle and the drink bottle thing, by all means, if you can access it, use it. Froggy Mouth is cheap and cheerful, readily available everywhere around the world. It has good literature to support its use. I'm favoring teaching things that have are science evidence-based, right? So I'm using Froggy Mouth because there's a reasonable amount of research done on it, and I like the concept because it's basically the same thing that I teach in my GoFX, but with a gadget. So that's what I advocate if you want a gadget. How much pressure to create suction hole? Very little. How much is little? I have no idea. But you can swallow very gently and create a vacuum seal. And effectively, that's what you need to do, right? Your swallow should be effortless, smooth, gentle. No need to force a swallow. Right? The action is what creates the vacuum seal. The amount of force you use is less important than the correct action. It should not be visible externally. Right? So that's how much pressure you use. Just enough to create a seal without you looking like you're swallowing. But if you want to use a gadget, Froggy Mouth is one that I would recommend. So that's a French product. There are distributors throughout the world. Where exactly, I don't know. Australia has them, the US has them. And I'm fairly certain that they distribute in different parts of the world as well. But by all means, look up yourself, research on MySpot, on REM Replenish, MyNozzle, and Uplock Vacuum Seal. All right, when you find the research, then you can justify using that appliance. I've not really done any research on those because I found two things that I'm happy with, my GoFX and the Froggy Mouth. So I use those. Last question, if an 8-year-old with an obvious canting due to body posture, do we treat this patient before or during after the body posture is improved, corrected? How do we treat this patient with appliances? We don't do any body work in dentistry because, well, it's not licensed to do so. So whether they have bad body posture or not is irrelevant to how I treat their oral posture and their occlusion. If you note bad body posture, by all means, work interdisciplinary with body workers. In GoPEX, we recommend that we also focus on body posture, but it's just a very general hold your back straight, fight gravity. The recommendations in my GoPEX are based on body work specialists, but other than a general sit up straight, stand up straight concept, it's not something that we really have any business in specifically addressing. I don't think there's any downside in recommending that children hold upright posture in seating and standing positions, but beyond that general commentary, we certainly shouldn't defer or advance or hold back malocclusion management based on their body posture. Right? We focus on the malocclusion and we make decisions on the timing of the treatment based on the malocclusion. and the age of the patient. And it's done independently on any other body postural issues that the child has. If you want the child to specifically correct body posture issues, then work with a body worker, physiotherapist, chiropractor, whoever's appropriate, and refer to them, get them to take the appropriate steps. And they'll work out their own plan according to timing and process. Okay.
All right, any other questions? I think that's been it so far. No other submissions online. So going once. I think that's it, Simon.
Great, good questions. Well done. Thanks, guys.
Okay. All right. Thanks, everyone. Good night. Bye. If you joined us late, we will upload the recordings by tomorrow on our YouTube channel. All right. Thanks all. Bye bye.